Hello everybody, welcome to Number 1 Doctor. A person sustained chest injury following a road traffic accident and presented at ER with severe respiratory distress. How will you manage? The management of this patient will be as per ATLS, advanced trauma and life support. Protocol of management, which includes primary survey and resuscitation, secondary survey, definitive treatment. Before proceeding to secondary survey, I will like to exclude life-threatening injuries like tension pneumothorax. If tension pneumothorax is present, relieve it by inserting wide-bore needle in second ICS. Massive hemothorax, relieve by inserting a chest drainage tube. Open pneumothorax, managed immediately by an occlusive dressing, sealing 3 sides and keeping one side open. Once chest tube is inserted, the wound is sealed on all sides. Cardiac tamponade. If cardiac tamponade is present, needle cardiocentesis is to be done by inserting a wide-bore needle to the left of xiphisternum. After stabilization of the patient, a detailed secondary survey is done. History of trauma. Other symptoms like chest pain, hemoptysis, angina-like pain. Symptoms due to injury to other regions. Examination. A detailed examination from head to foot. Detailed chest examination, inspection, respiratory rate, symmetry of chest wall, contusion. Any bruise or laceration or open wounds, paradoxical respiration, flail chest, stove in chest, indented segment, movement of chest. Palpation, mediastinal shift, position of trachea and apex beat. Tenderness over the rib. Palpable crepitus, surgical emphysema. Movement of chest. Percussion, normal resonance, hyperresonance, pneumothorax. Dullness on percussion, hemothorax. Auscultation, breath, sound present or absent, any added sound. Investigation. Baseline investigations. Chest X-ray PA view. A simple chest X-ray may show rib fracture, pneumothorax or hemothorax. Chest CT scan in selected cases. Arterial blood gas analysis. Their investigations if patient has other associated injury. What is the implication of first rib fracture? First rib fracture is usually due to a severe violence. When first rib fracture is diagnosed, further investigations are required to exclude associated vascular or brachial plexus injury. What are the implications of lower rib fracture? When there is fracture of 8th to 12th rib, further investigations are required to exclude liver, spleen or kidney injury. How will you treat isolated rib fracture? Isolated rib fracture without underlying lung injury may be treated by analgesics, non-steroidal anti-inflammatory drugs like diclofenac or aceclofenac, intercostal nerve block, respiratory physiotherapy. What are the indications of thoracotomy in traumatic hemothorax? Thoracotomy is indicated in following situations. Massive bleeding, more than 1 liter of blood drains on insertion of chest tube. Brisk bleeding, bleeding more than 100 ml every 15 minutes for 1 hour. Continuing bleeding, bleeding more than 200 ml per hour over 3 hours. Associated major airway injury requiring thoracotomy. A posterolateral thoracotomy is done, the bleeding vessel identified and secured by ligation. Chest closed by placing an intercostal tube drain. How will you diagnose traumatic pneumothorax? Traumatic pneumothorax is suggested by respiratory distress, mediastinal shift to opposite side, diminished movement of the hemothorax on affected side, hyperresonant percussion note on the affected side of the hemothorax, absent breath sounds. How will you diagnose traumatic hemothorax? Traumatic hemothorax is suggested by presence of shock, respiratory distress, chest pain, mediastinal shift to opposite side, restricted movement of hemothorax on affected side, dull percussion note, absent breath sounds. Diagnosis is confirmed by a chest X-ray. What is the source of bleeding in traumatic hemothorax? In most cases, bleeding is due to injury of intercostal vessels. Bleeding may be due to laceration of underlying lung. Rarely major vessel injury. How will you treat traumatic hemothorax? In traumatic hemothorax, the drainage of accumulated blood is essential, as blood is a good culture media and infection of accumulated blood may lead to emphysema. Accumulated blood may result in fibrosis. Hemothorax requires drainage by insertion of a chest tube. How will you treat traumatic pneumothorax? Tension pneumothorax. Immediate relief at emergency by inserting a wide-bore needle at second intercostal space at mid-clavicular line. Subsequently, a chest drainage tube is to be inserted through the second intercostal space or through the triangle of safety. Massive pneumothorax with collapsed lung needs intercostal tube drainage. Small pneumothorax with a partially expanded lungs may be treated with analgesic, chest physiotherapy, antibiotics. What are the indications of thoracotomy in cases with traumatic pneumothorax? Continuing air leak for more than 7 days. Massive air leak suggesting major airway injury. Associated lung contusion. What is tension pneumothorax? A tension pneumothorax develops when one-way valve air leak occurs through the lung or chest wall. Please like and share this video. Subscribe to No1doctor channel on YouTube. Air is forced into the pleural cavity without any route of exit. There is complete collapse of the affected lung and there is shift of mediastinum to the opposite side, compressing the opposite lung. There is also decrease of venous return to the heart. The tension pneumothorax is clinically diagnosed by chest pain, respiratory distress, air hunger, increased jugular venous pressure, mediastinal shifting ascertained by shifting of trachea and apex beat to the opposite side, tachycardia and hypotension. Hyperresonant percussion note. Unilateral absence of breath sounds. How will you manage tension pneumothorax? This is a life-threatening condition and requires immediate relief by inserting a wide-bore needle through the second intercostal space at the mid-clavicular line. Subsequently, a tube thoracostomy is required by placement of a chest drainage tube through the fifth intercostal space at the triangle of safety. How cardiac tamponade may occur following trauma. Cardiac tamponade usually occurs following penetrating chest trauma. However, cardiac tamponade may also occur following high-speed blunt trauma. Accumulation of even 15–20 ml of blood in pericardial cavity may result in features of shock due to inadequate cardiac filling. How will you diagnose cardiac tamponade? History of penetrating or high-speed blunt to the central chest. Beck's triad, hypotension, distended neck veins, muffled heart sounds, pulsus paradoxus. Kussmaul's sign, raised jugular venous pressure, JVP during inspiration. What investigations helps in diagnosis? Chest X-ray, globular heart, ECG, low voltage complexes. Fast fluid in pericardial cavity. Treatment, pericardiocentesis. Thoracotomy and percardiotomy and tackling of injured vessels. What is flail chest? When more than 2 ribs are fractured at 2 or more places on one side of the chest, or on either side of the sternum, then a segment of the chest wall may lie separated from the rest of the chest wall and this flail segment moves paradoxically during respiration. Why there is paradoxical movement of the flail segment? Inspiration is an assist process. The intercostal muscles contract, the diaphragm descends. There is expansion of the chest cavity resulting in negative intrathoracic pressure, and air is drawn in. During expiration, which is a passive process, the chest wall recalls and air is exhaled out. The flail segment of the chest wall lies loose from the rest of the rib cage. During inspiration, the flail segment does not move outward along with the rest of the chest wall. Instead, the flail segment is drawn inwards due to the negative intrathoracic pressure. During expiration, the chest recalls and this results in a positive intrathoracic pressure. So the flail segment is pushed outwards. This reverse movement of the flail segment during the phases of respiration is called paradoxical movement of the flail segment, as the flail segment is drawn inwards during inspiration. This prevents expansion of the underlying lung, interfering with gaseous exchange in that segment of lung and results in a right-to-left shunt leading to hypoxemia. What is central flail chest? When there is fracture of ribs on either side of the sternum resulting in a flail segment of sternum is called central flail chest. What is lateral flail chest? When there is fracture of multiple ribs on one side resulting in a flail segment on one side of the chest is called a lateral flail chest. What is minor flail chest? If the flail segment is small and does not interfere with respiration and does not cause alteration of arterial blood gas analysis is called a minor flail chest. How will you manage minor flail chest? Patient should be treated in an intensive therapy unit. Analgesics, respiratory physiotherapy, incentive spirometry, serial arterial blood gas analysis. Patient usually gets stabilized in 2 to 3 weeks. Some cases may require ventilatory support if there is deterioration and if there is development of hypoxemia. What is major flail chest? The flail segment is large and interferes with respiration, resulting in alteration of blood gas analysis leading to hypoxemia and hypercarbia. How will you manage major flail chest? Patient should be treated in an intensive therapy unit. Patient needs intermittent positive pressure ventilation, for about 2-3 weeks. The flail segment gets stabilized in 2 to 3 weeks' time. General care, intermittent suction. Care of skin, antibiotics. Bowel and bladder care. Maintenance of nutrition. Routine fixation of flail segment is not required. However, if there are other underlying injuries requiring thoracotomy, the flail segment can be fixed simultaneously. What is sucking wound in the chest? A penetrating injury in the chest wall through the pleura is called a sucking wound in the chest. The underlying lung collapses as air moves in through the open wound during inspiration and air moves out of the pleural cavity through the wound during expiration. This results in inadequate ventilation of the underlying lung, resulting in a right to left shunt leading to hypoxemia and hypercarbia. How will you manage a sucking wound of the chest? The wound is sealed with an occlusive dressing, which is taped on 3 sides and kept open on one side to allow expulsion of air from the pleural cavity but prevent sucking in of air into the pleural cavity. It is necessary to exclude underlying injury to lungs, heart or major vessels. The wound is repaired and chest tube